Hi, everyone. Great. Well, welcome back. So 2 down, 2 to go. I'm incredibly excited to get to introduce our next team. But first, a friendly reminder for something I'm sure you all know, to silence all phones and ringers, if at all possible, just for our live feed. We would appreciate that. Thank you very much. So without further ado, we'll move on to the second half of the competition today with the University of Pennsylvania Team Remind. I'm going to have them first introduce themselves, and then we'll get started.
My name is Megan O'Brien. I'm a fourth-year medical student at the University of Pennsylvania, and I'm also getting my master's in bioethics.
I'm Dan. I'm an undergraduate at Penn and also a FELS Master's of Public Administration student, and I'm Penn Student Body President.
I'm Kayla. I'm a second-year social work student in the School of Social Policy at Penn, and I work as an inpatient case manager in a psychiatric hospital.
Hi, my name's Molly. I'm a doctoral student in the School of Nursing, and I work as a nurse in the emergency department at Jefferson University Hospital. And we just wanted to take a minute before we began to address a question we got a couple times yesterday, which was how on earth the four of us got together. We're all from different schools within the University of Pennsylvania, and we each applied to the policy challenge with the healthcare idea based on our interest and experience in healthcare, and came together about 3-4 months ago with at least 4, if not 16 different competing ideas, narrowed it down to this idea and really hit the ground running. So we're pleased to be able to show you how far we've come in those 3 months. Thank you.
You guys hear me okay with this mic here? Okay. So our idea for this challenge grew out of our collective experience in healthcare and thinking about the impact that no-shows have on patients, their doctors, and the community. Specifically, we were interested in the vulnerable population of the mentally ill, for whom gaps in care can have particularly deleterious consequences. If we think only in terms of money, the cost of no-shows in this population in Philadelphia is nearly $10 million a year, and that's to say nothing of the personal toll that the consequences have on patients and their families. So in order to address this problem, we decided to think big but start small with a micro-intervention of a text message reminder system that will help patients who have recently been in psychiatric hospitals get to their first outpatient appointment. We think, and research suggests, that our idea will not only improve patient care and eliminate systemic waste on the order of millions of dollars, but that it will generate an important data collection tool that will inform a series of future cascading interventions. We call our idea Remind. So to illustrate the problem we seek to address, I'd like to tell you a story about a patient. Since I have to change the name anyway, I think today we'll call him Patrick. He's a 25-year-old attorney who has recently started hearing voices that other people don't. Sometimes these voices tell Patrick to do things that are illegal, and when he's overwhelmed by the voices, he listens to them. So when the police pick him up, Patrick ends up in the hospital, admitted for psychiatric care for treatment of his new diagnosis of schizophrenia. Every year in Philadelphia, over 11,000 patients are admitted for inpatient psychiatric care and begun on treatment programs. Before they are discharged, they will be set up with an outpatient appointment so that they can continue the care that was begun in the hospital in the outpatient setting. All of these patients, like Patrick, will leave the hospital with a stack full of discharge paperwork in which will be buried their appointment information. And so it's no surprise that, on average, 42% of these patients never make it to that initial appointment. The #1 most common reason why is that they forget. And as you might imagine, serious mental illness requires long-term treatment to maintain recovery. When patients don't make it to their appointment, they're less likely to adhere to their medication and treatment plans, and up to 50% more likely to drop out of care altogether. And while 90% of patients who make it to that initial appointment will stay out of the hospital for a year, 25% of those who miss that appointment will end up back in the hospital within 12 months. And in Philadelphia, those numbers are even higher. So as you can see, making it to that first appointment successfully is a critical first step in care continuity. Now, the problem is that Patrick's outpatient doctor won't take responsibility for Patrick until he actually shows up at his door, leaving Patrick and patients like him vulnerable to falling through the cracks during this critical transitional period. Well, why do we care? Well, first, no-shows affect patients. When patients drop out of care, they're more likely to decompensate and become a threat to themselves or others. No-shows affect outpatient providers, who, as one of our stakeholders said, are losing their shirts thanks to the lost revenue due to no-shows. No-shows affect hospitals. As we increasingly move towards a pay-for-performance model, hospital grades and thus reimbursement are tied to readmission rates. So when patients drop out of care, no-show, and get readmitted, it affects the hospital's pocket. And lastly and importantly, no-shows affect communities. When the mentally ill drop out of care, they're more likely to suffer a mental health crisis and require the use of valuable community resources like police and emergency services. In addition, since the mentally ill face disproportionate rates of incarceration, they're more likely than average to end up in the expensive prison system. And since Medicaid is the single largest insurer of the mentally ill, preventable rehospitalizations represent a drain on the public fund. In Philadelphia, the cost of rehospitalizations for just those mentally ill patients who never make it to that first appointment is nearly $9.5 million every year. And to give you a sense of scale, the cost of an outpatient appointment is about $150, and the cost of the day in the hospital is nearly $1,500. So that's where that number comes from. In light of recent budget cuts, now more than ever, we have to more efficiently utilize the mental health care resources we have so fewer patients fall through the cracks. So again, we decided to think big, but start small with a micro-intervention that will trigger a cascade of future interventions. Our idea is, we think, elegant in its simplicity. We want to use reminders, primarily text messages, as a cost-effective way to get patients to keep that initial appointment. Our service will exist as a website, remindphilly.org, that will be available to hospital discharge planners and social workers. It will take users a maximum of 5 minutes to log on to this user-friendly, password-protected, HIPAA-compliant website and enter the necessary patient appointment and provider contact information. And patient contact information. The website will then automate 2 text message reminders in advance of the patient's appointment. It will have the capacity to generate an email and a phone call reminder as well. And so that the appointment information is separate from that stack of discharge paperwork, it will also generate a handout that the patient can have with directions and appointment information. And since our collective experience in healthcare tells us that family members are often involved in caring for the mentally ill, the patient can sign a consent to allow a collateral contact to receive the appointment reminders as well, so it can be a team effort in getting them to their appointment. Now, our idea for this project didn't come out of nowhere. In fact, it's research supported. In 2012, a British pilot study looked at the use of text messages as reminders to get inpatient psychiatric patients at 4 hospitals to get to their outpatient appointments. They saw a reduction in no-shows of 27%, which in terms of healthcare is a huge number. If you scale that up annually on a national level, that is a savings of $245 million for Britain. Similarly, in 2008, Kaiser Health Systems in California, which is a system known for its cost-efficient innovations, ran a 1-month text message-based pilot reminder study in 1 clinic, and in that 1 month in 1 clinic alone saved $275,000. Their CIO was impressed enough to greenlight the program as an upcoming national initiative, and so are we. So in order to implement Remind, we thought it best to follow the money. So money for mental health in Philadelphia starts at the state level, flows to the city level, and then the city contracts a nonprofit organization called Community and Behavioral Health, or CBH, to charge them with administering mental health services to the city's 420,000 mentally ill. 420,000 Medicaid recipients, some of whom are mentally ill. So we thought it best, as part of our policy of thinking big and starting small, to start at the lowest 2 rungs on this ladder, at the level of CBH and the level of the providers who accept CBH as their insurer. And within these bottom 2 rungs, we thought we should go straight to the top. So we met with Dr. Matthew Herford, the Chief Medical Officer of CBH, and we pitched him our idea. He called Remind a no-brainer, and here's why. First, Remind represents the first step in a cascading interventions. It will reduce no-shows, reduce readmissions, and importantly, liberate the money saved for reinvestment into mental health service improvements for all Philadelphians, including those for whom a text message reminder system may not be effective or appropriate. Secondly, it represents an important data collection tool. So currently, CBH has information on patients who are receiving outpatient treatment by looking at their claims data. But they don't know if patients who are mentally ill who are not getting outpatient treatment are not getting treatment because they're never showing up to their appointments or because they were never made appointments. So by collecting data on appointments made, Remind fills in this important data gap that allows CBH going forward to target its continuity of care interventions to those patients who are most in need. This is the next step in the cascading intervention. So not only did Dr. Herford call Remind a no-brainer, but he said that once we get Remind up and running, which we hope to use these challenge winnings to do, that he has space in his budget for implementation and maintenance costs, which you can see here are quite modest. And most excitingly, just this past week, he brought us back to the table with important key stakeholders at CBH, including the Director for Member Services, the Deputy Chief Medical Officer, the Director for Research-Based Quality Improvement Initiative, among others, and they love the idea so much that they brought it straight to their CEO just this past Friday, 2 days ago. And we are pleased to announce, for those of you who didn't hear us yesterday, that we have officially partnered with CBH to make Remind a reality. And while the buy-in of these key stakeholders means that Remind is in fact shovel-ready, we realize that for full implementation, we need to get those who are charged with using the service on board. And we've already made many important inroads with hospital discharge planners and social workers. For full implementation, we'll launch a simple educational campaign. As you can see from our timeline, within 2 months, we'll have the website up and running. We'll begin piloting over the summer, and then in the fall, we hope to have Remind up and running, collecting data and connecting patients to appointments. If you think the Remind service seems obvious, you are right. However, something like this doesn't yet exist in healthcare because healthcare typically lags behind the health information curve and there's tremendous limitations on existing personnel. And quite frankly, reducing readmissions hasn't been a top priority for hospitals until the Affordable Care Act has recently made it so. We wanted to use this technology thoughtfully to take the responsibility of implementation and maintenance costs out of the hands of the individual hospitals and centralize it at the level of CBH to eliminate an important barrier that will allow hospitals to access this service for the first time. We'll reduce no-shows, reduce readmissions, save a lot of money, and generate a data collection tool. But importantly, we'll also create a model that can be recreated in other realms of healthcare for other chronic diseases and across the nation, hallmarking Philadelphia as a national leader and an innovator. If Remind helps just 3 patients stay out of the hospital, it will have recouped its implementation and maintenance costs. That's our break-even point. If we see a reduction in no-shows at a rate similar to that of the British pilot study that serves as its model, we'll save Philadelphia $2.5 million, and that's a conservative estimate. That's an 8,000% rate of return on investment. Most excitingly for us, if we keep patients like Patrick connected to the services that they need, we can quiet the voices, get them back to their jobs, and get them back to their families. And this is an immeasurable social return on investment. At this point, I probably don't need to remind you that helping patients like Patrick help themselves means a stronger community for us all.
I'd like to ask a question. Under the ACA, the whole idea of reducing or eliminating payment under Medicare for readmissions is to really incentivize the hospitals to sort of get outside their walls and take some action and make some investment in making sure that their patients, when they leave the hospital, are followed and connected with someone. We are working a lot with the community-based behavioral health organization, and yet this is going to reap a lot of benefits to the hospital financially. As well, it will take extra work on the part of the hospital social workers, and I see that you're connecting with 4 different departments in the hospital. The hospital CEO and CFO would probably be very interested in this, and I'm wondering if you've explored getting investment in your initiative from the hospital, as they will be making they will be getting the benefits of this financially, and as well as their patients doing better.
Thank you. That's a great question, and that's exactly what CBH said the first time we talked to them. Why us? Why should we pay for this, even though it is a modest sum? And our answer to them really was because it'll help you collect data. And as Megan said, they really don't know what's happening when patients leave the hospital, and if they're being made appointments, and if they're making the appointments. So this idea that CBH would be able to collect data to inform these cascading interventions that we're talking about, that really appealed to them. Now, if this had come with a huge price tag, I think they would have just said no, but they said we're willing to try it, and down the line, explore how providers can be responsible for this.
answer your question?
Yeah, I just think long-term hospital investment in this is going to be critical, since they are going to reap the financial benefits of lower admission rates, lower readmission rates.
Yeah, I agree with you. The reason that we sort of went to the, I guess what you would call the insurance company, because that's what Medicaid really is because these costs are really small, but for a hospital, especially a nonprofit hospital, which the majority of the hospitals in Philadelphia kind of are operating at that margin, $30,000 is an astronomical sum. So we have sort of explored the option of getting people to have to pay sort of a service fee for using this eventually. But really the benefits are spread over a really large group of people. It's the hospitals, and it's also the outpatient providers, and it's also Medicaid. So we just sort of went to the biggest source of funding because we felt like that was what's going to make it the most sustainable. And we really want to make sure that this isn't in place for just 5 minutes. It lasts for a long time, because we really do believe that this can help people.
Definitely.
Yeah.
And I know Dr. Herford probably already asked you this question, but you really just kind of gloss completely over HIPAA compliance here by just saying, oh, it's HIPAA compliant. Yeah, don't worry about it, it's HIPAA. But that's a major, major issue, particularly in all aspects of healthcare, but particularly in the mental health area. What kind of safeguards do you have for the patients that they're not going to get, somebody's not going to have their phone and they get a text that, oh, you got to see your psychiatrist on Thursday kind of stuff. So tell us a little bit more about the patient protections.
Right. HIPAA is a very real concern, especially for this population, because we know that when it comes to mental health, people don't want that information being spread around. And so we've been very careful throughout this process to really ask those tough questions. What does it mean to be HIPAA compliant in the new web interface age? And when we met with the Chief Information Officer at CBH, they had similar concerns, but they were so excited about the project, they said they'd find ways to address them. One of those ways is to create this as a password-protected site. So there are safeguards simply in the access of information, both by the external providers, but also in the hospital. So only people who have been given permission to use the patient's information are entering that information and seeing it. When it comes to getting the text information and how that is HIPAA compliant, first is, of course, that it is opt-in. None of this information is sent without explicit consent and opt-in consent from the patient to make sure that they're saying, yes, I do want you to send this information to my phone, even if I'm not holding it at that moment. Or more importantly, yes, I want you to send this information to my parents, who might not be me and covered under HIPAA. But the third way we've thought about accessing it came from our meeting with CBH is the actual content of the information that's going to go out over the phone, over the text, and over the email. So when it's going to a collateral contact, like a family member, one of the things that CBH talked about is perhaps changing what the text says so that it won't actually release confidential information about the nature of the appointment, the doctor's name, the illness being discussed at the appointment, but rather only the crucial information that would help the patient get to the appointment without actually sharing what is going on. And in that way, both you protect the patient's privacy, but also remain compliant with HIPAA. And CBH, who's worked with this a lot more than we have, feels confident that this is HIPAA compliant, although it's definitely an important question to be looked at throughout the process.
Just as a follow-up to that question, what would the language look like in your contractual relationship with the hospital or with the healthcare behavioral organization around the issue of privacy?
Good question. I just want to make sure that I answer it correctly. You want to know what our contract is going to be with CBH, which is Medicaid, basically?
That's correct.
Or what CBH's contract is with the hospital, or both?
Wherever you're contracting to
let's
do
get,
this.
Let's get it all out there.
Wherever you're contracting to have access to patient information.
Oh, okay.
What is the legal construct around your contractual relationship such that the privacy issue and HIPAA issue are resolved?
Okay. Thank you for bringing that up. I don't think that it's been brought up before, and it's an important point that we want to make sure we have clear. The fact of the matter is that CBH, Medicaid, already has legally access to all of this information. If they wanted to, they could go to my hospital, for example, which is on paper records. It's not on any sort of electronic medical records. And they could physically go and take a patient's chart and flip through it and find all of this information. Now, they probably won't unless there's a big snafu somewhere along the line, because it's time-consuming, and why would they bother? And to try and get that information on 11,500 people every year is overwhelming. So just to clarify, they do have legally access to this information, as does any insurance company. Any insurance company legally has access to your medical information. Now, to answer the the second element, what's our relationship with CBH? We would obviously have to enter into a contractual agreement, as would any healthcare provider, which we are all very familiar with, that is HIPAA compliant and notes that we don't share any confidential information and that we only have access to the level of information that we need. So to that end, what we're expecting the website, remindphilly.org, to produce is basically a monthly or a quarterly data sheet that will give just sort of records and information on what's been entered in. And somebody who needs more specific information can log in sort of through a backdoor and be able to access that very specific, patient-specific information. But what the average person and average data cruncher working at CBH, and probably ourselves as well, will have access to is just a sheet of numbers. Does that make sense? Does that answer your question? Okay, thanks.
So I'm wondering, you say you're thinking big and starting small, which I appreciate, and you talk about cascade of future interventions, and I'm just curious what your bigger vision is for where this would go next and how you'd build on it.
We're excited about that too, the opportunity for this to be not just Philadelphia and not just mental health patients. The exciting part for us is that during this process we focus laser-like on Philadelphia, and that's why here it makes sense to work through CBH, whereas in other locales it might not. But the exciting thing is that at this time next year, in the holiday season actually, in 2014, we'll have already saved the city of Philadelphia $2.5 million and let hundreds of people who would otherwise be in the hospital be back home celebrating the holidays with their families. That's why it's so nice that we have the local impact in Philadelphia and the opportunity to scale this up here quickly. But when thinking about expansion, that can happen quickly as well. There are two ways that we like to talk about expansion. First is vertically. How do you help the people along the mental health pipeline who aren't going to be served by this service? As it's mentioned, we can only get about 1/3 of people who would otherwise miss their appointments to show up. In healthcare, that's huge, and we know that translates directly into $2.5 million in savings. But how do you get those other people that are going to miss their appointments or that are going to go to their appointments but still not be treated properly? Part of that we're going to use the data we collect from the service to inform future interventions. The example we like to give is one of the problems people have getting to their appointments is they don't have transportation. They know when it is, they know where it is, but they can't get there because they don't have a car, they don't know how to use public transportation or can't afford it. So maybe one of those future interventions is to give a subsidy for public transportation so that they can get to their appointment on time and at the right place. The other expansion, which I think you're getting at more clearly, is what happens across the horizontal expansion. We think of this both as other diseases, because mental health patients aren't the only ones who are missing their appointments. In fact, the no-show rate is actually pretty similar across the board, across different diseases. A great example is heart failure. And if you don't show up for your follow-up appointment for heart failure, you're almost guaranteed to end up back in the hospital. And those rehospitalizations are even more expensive than for mental health. So we can work with the existing partnerships that we're going to establish with these hospitals to expand across departments. But the other thing we can do is expand geographically, because what Remind is the infrastructure to support this type of reminder system. And I think it gets to the question you were asking earlier, which is, what about hospitals? Can they be involved? In Philadelphia, we're very confident that CBH is a group that makes sense, both because they're willing to invest in it and partner with us on implementation and collecting the data, just like you would for any other trial or pilot program, but that in other cities it might make sense to go directly to the hospitals who do have a financial stake in this, and to provide them the service of Remind so that they can log on, they can create their own infrastructure, because really all that's happening is they're entering the patient's information, and that information then is going back to the patient to be reminded to show up for whatever type of follow-up it is. So we do expect rapid escalation and scalability of this project, hopefully reaching into the hundreds of millions range very quickly.
Well, to that point, I think you have designed and communicated and envisioned a short-term objective here. You spell out your plan for getting this become an integral part of CBH's operational format. But I don't think you've given yourself the opportunity to get to the long term. You don't build in any financial resources that will allow you to do that. For example, here in your budget, you're only going to have a 6-month, 20-hour staffer working at below minimum wage rates.
Part-time.
Well, annualized, that's $19,000 a year, okay? And you indicate here 3 specific functions of that person, the third of which is to transition it over to CBH. So where are you going to get the resources and to build the internal expertise that will allow you to transport this model to other areas of medical care and in other communities? That's where I don't see you really taking care of your future. And then on that point, knowing the self-described background, each of you are already immersed in your graduate studies. You are essentially the founders of this model. Which one of you is really going to be continuing with this? Because I think it's important that you can't take your vision and your energy and transfer it to someone else.
Pick me. So good questions, and I say pick me because it would probably end up being me, just because I have the most experience in this field, and because I'm already connected with a lot of the on-the-ground stakeholders who we would expect to be responsible for actually carrying out this duty. I do want to go over the budget in a little bit more detail, just to make sure that everyone's sort of on the same page. You got the numbers exactly right. We're planning on hiring somebody for 6 months. $9,500 is reflecting a part-time salary, which would translate into like a $40,000 a year salary, which
We
I felt
negotiated her down.
Yeah. But if you think that it should be more and you want to tell them that, then I won't stand in your way. We have reflected the cost of $22,000 annually to increase basically a data management staff, which is going to be the person who's going to be looking at this data by 0.5. We spoke about this with CBH. They initially said that they actually don't need this, that they already have existing staff and personnel that would be able to assume these responsibilities. But when we pitched this exact budget to them, they were on board with it. So they are on board with funding this position should it appear to be necessary. So that being said, what is not in the proposal is the cost of carrying out sort of these like bigger initiatives and the cascading interventions that we've discussed so much about. And that is very much on purpose. The reason being that we can't predict what those interventions are going to be because they are going to be informed by the data. You've really caught us at kind of an exciting moment, we think. We're really at very much on the ground level of what we think is going to be a really big movement and a really big change in patient care in Philadelphia. We don't know where it's going to go, but we do feel really confident that the data that we produce will inform those cascading interventions and that the money that we're going to save will be able to fund them.
Yeah, that savings is not coming to you. My only point is, I think you should expand your budget and you should create the opportunity for growth. You should actually ask your initial funders to give you more money and indicate that part of it is to take you to phase 2.
Yeah, I think that's a great point. And as I was saying in the beginning, we did just come together 3 months ago, and as Kayla said, it's exciting, and it's, to be honest, kind of shocking how far this has gone and how it's actually going to be implemented. So not that we didn't believe in our idea at first, but we are like really, really strong believers now, and we'd love to be able to take this from what it is now to something else, but we're looking for tips in that regard.
Can you tell us a little bit more about either the London experience or research about the relationship between a mental health patient and the medium of communication? Is a text message seen as a text message, or if Patrick gets sick, does it become another voice? I mean, is there any research about that?
So the London study specifically looked at the endpoint of no-shows, and they broke it down by sort of disease category, looked at employment status and homelessness. So they didn't look at that specific endpoint in particular, but you know, this is, again, as has been said by my teammates, this is going to be an iterative process, and that could be very much something that we look at. I don't know that it will end up being another voice, but it certainly is important to see if this is a burden on patients. But to give you some sense of our perspective on it, is all of these studies had an opt-out rate, and the opt-out rate was less than 1% in each. So this suggests that patients in fact, want text messages. And other studies that we didn't mention in our presentation looked at, compared text messages and their cost effectiveness and sort of their acceptability on the patient receiving end, and it showed that they were more desired than phone call reminders. So that's why we really focused on text message, for the cost effectiveness and for the patient desirability of this particular type of reminder. But how that interfaces with patients who are mentally ill, that's a good question. It's something that we'll be thoughtful of when we go forward as we start to roll this out in our first iterations.
Very good, thank you.
And sorry, just
So
to tag on to that, should anyone be interested in the data, we really stand behind it. There is an annotated bibliography that's in totally non-nerd terms that's available by emailing remindphilly@gmail.com.
So, hang on just a second. Just to foot stomp Mayor Johnson's point a little bit, I mean, you've been flying fast with a great idea. In 4 months, you've covered a lot of ground. I think you've hooked on to some degree of sustainability through CBH, but it's your idea and the furthering of your idea that we're concerned about. You know, where does it go without you? CBH and the budget you showed will sustain it for the niche area that you've described, but if this idea is as good and as big as we think it is and you think it is, it needs to have your energy amplified through some mechanism, whether it's a partnership with an existing 501(c) or one that you create yourself in order to allow it to expand.
No.